Hello and good afternoon. You're listening to Atiyah Ali on the Mental Health and Emotional Wellbeing Show on Ramadan Radio Wolverhampton, online on ramadanradiowolves.com. In the show today, we're hoping to provide information that may be helpful to support your wellbeing and the wellbeing of others, because everyone's mental health matters. In the last show, our guest, Michael Cole, a sports exercise therapist, and Richard Buscombe, a sports scientist, provided insight to sports psychology. You can listen back to this on Ramadan Radio's YouTube channel, alongside finding further information on mental health on my Twitter feed at Atiyah Ali 3. We are not here to offer you advice in place of your clinician. However, we will share information that may encourage you to seek support. If you feel you need to discuss your health and well-being following this show, then please do contact your GP. We won't be taking any live calls within the show today. However, we welcome your comments via the WhatsApp messaging number on 07 440 420 432. That's 07 440 420 432. We are currently hoping that during this COVID-19 pandemic, we will be able to focus on our emotional well-being and find strategies to help us with this. In one of our previous shows, we focused on COVID-19 and self-care. Please listen back to this for further information on managing your well-being during this difficult time. In the show today, I'm pleased to introduce Dr. Sukhbir Bilku, a senior clinical psychologist in a local NHS eating disorder service and also in private practice. Dr. Bilku is also part of Seek Your Mind, which is a local mental health organisation helping the Sikh and wider community to access the culturally sensitive and faith-based service. Welcome to the show, Dr. Bilku.
Thank you.
I'm just wondering from the outset, what is the role of a psychologist that specialises in eating disorders? Could you tell us a bit about that?
Yeah, sure. So the role of a clinical psychologist within an eating disorder service is quite varied. Ultimately, we want to support a patient and their family from the point of referral into our service all the way to discharge, to make their journey within our service as safe enough for them as possible. So we, at the first point when they come in, we assess the person to determine how severe the eating disorder might be, or whether it is an eating disorder or something else underlying, or wider in the context of mental health difficulties. Part of my role also is about providing therapy for the young person as well, or the older person, because we're an all-age service. So I do see young people, children as well, I suppose, sometimes, and young adults as well. Providing consultation to other services as well to help the person, because sometimes when a person has an eating disorder, they also have other comorbid difficulties as well. So it might be that they're already under the care of another service, and it's really consulting with them about their care in that service and in our service, so we don't overlap.
Right.
And we also provide training and supervision within our team as well to the nurse therapists, occupational therapists and the dietitians as well, just to help facilitate a holistic package for that young person and the family as well. I provide loads of different types of individual therapies as well with the young person, depending on their need, really.
So is this the NHS service you're talking about, or
yeah,
both?
So I work in a local NHS community service, so we're an all-age service. The setup of eating disorders is quite different nationally, so you can have an inpatient service or a community service, or a specialist service, like a tier 4 service, but we're a community service essentially.
Okay, thank you. It sounds like a very interesting and varied role, and it sounds like you're advising lots of different professionals within the field. How many people do you think are currently affected by eating disorders, or are there any statistics around this?
Yeah, so the thing about statistics is that statistics only rely on those that have had a diagnosis or have been recognized as having an eating disorder. There's lots of people who haven't been diagnosed and living with an eating disorder or disordered eating that we don't know about. But current figures based on, I suppose, from Beat website and from NICE guidelines is around about 1 million to 3 million per year with a diagnosis of an eating disorder, which is quite a lot. But that's not to say that there's quite a few out there that haven't been diagnosed. In terms of the ratio, commonly eating disorders are quite have been known as a kind of gender orientated diagnosis of an illness. So people tend to think of historically as it's a white female led illness, but actually we know that's quite different now, and eating disorders genderless and ageless as well. The ratio does tend to be higher in females, but we are recognising around about 25% of our service, and those nationally are in the male category as well.
Right, so 25% are in the male category. That's quite substantive, isn't it?
Yeah.
And it is different to what we hear in the media and elsewhere.
Yeah, sure, kind of, but I imagine there's lots of men out there that still see it as a kind of gender orientated illness, and that holds them back from seeking support or even kind of going to their GP or somebody else to kind of think, have I got an eating disorder or not, or is this something that I'm just experiencing, it's not, and not knowing where to go. Sadly, kind of stigma holds us back, doesn't it, from accessing support.
Right, yeah. Stigma is another issue that we will come on to. I'm just wondering, in terms of eating disorders, would you be able to provide some information on some of the common eating disorders? I mean, what I'll do is we could focus on, let's say, one of the main two, if you agree, anorexia nervosa and bulimia. Would you say they're the main two in terms of disordered eating? When I say main two, they're the ones that people experience the most. Is that right?
Yeah, so they're the ones that commonly come in for those with, so eating disorders fall within a spectrum. So we start off from disordered eating. So think it as a spectrum all the way to an eating disorder. Eating disorder will come to the more of the end point of the disordered eating end, if that makes sense. By that point, it's severe, it's intense, and it's kind of life-threatening at that point. And that's where we kind of think about a diagnosis of eating disorder. It's way more than disordered eating. The two common ones we do get are anorexia and bulimia. Do you want me to explain a bit about them?
Yes, please. I mean, could you? Yeah. Could you do that? So, should we start with that? Should we start with anorexia? So
we'll start with anorexia, but just to say that both are very similar. So both are kind of in terms of presentation. So both have similar symptoms in terms of a body image, difficulties, or distorted thinking patterns, or preoccupation with food. But essentially, both anorexia and bulimia are differentiated by the food-related behavior. So with anorexia, for example, anorexia nervosa, there's more a kind of a restriction of food. So a person could be restricting severely their food intake, worrying about their weight and how their body looks. Their perception of their body by this point is not how they perceive it. So with someone that's in the midst of a really severe anorexia presentation, when you ask them what they see in the mirror, it's not what we would see. So they would see themselves as quite fat, for example, or you can say to them, no, you're not fat, but they won't see it like that. So by that point, we call it it's quite a egosyntonic illness, anorexia. It takes away your perception and really distorts your world and your thinking ability as well. And it includes compensatory behaviors as well, such as over-exercising, can include laxative use or any kind of kind of ways to lose weight as well.
Okay.
And I just wanted to kind of, when you read out symptoms of something like anorexia or bulimia, sometimes it's kind of hard for someone to relate. So, but I just wanted to read a little letter really from, it's available online, but it's kind of called A Portrait of a Manipulator, and it's by Rhonda, age 17. Obviously the name has been anonymized, but I just want to read a paragraph of a letter to show you and the audience, I guess, what anorexia is like. So it's just a quick in a minute. Okay. So if asked what anorexia looked like, I couldn't say. This is because anorexia has been so cunning and manipulative that she's taken on my own form. She came to me apparently anxious to win a friend and promised to take on all the negative aspects of my life and with permission to take care of them. By taking on these parts of me, she then became my darker form. She became all bitter, vindictive and negative aspects of my character. In doing this, she promised me all that I would be free to enjoy my life without worrying or feeling guilty because I wasn't a good person. Now I feel she has become such an integral part of me that by facing up to her and pushing her away, I would almost be cutting up a part of myself. Anorexia has left me my eyes to a certain extent in that I can see her and her ridiculousness, but she has anorexic grip hold on me so tight she won't let go. She makes you believe in her. She makes you such hopeful promises. Although my eyes struggle to tell me to reject her logic, she has her grip on that place that counts. That's just a bit from the letter, really. But the letter just highlights how much an anorexia becomes a part of that person's identity. And by the point when sometimes they come into our service, they don't know who they are anymore. They become the anorexia. And part of the work of a psychologist to help them understand, you know, how powerful and seductive anorexia can be from the spectrum of eating disorders. Anorexia is quite the sexy seductress presentation. Gives you everything, gives you a purpose, gives you a life, gives you an identity, almost like a religion, but it will take a lot away from you. And that's what anorexia is like for a lot of people.
Thank you for sharing that. And I think what I'm hearing you say is that the spectrum, so from disordered eating all the way to eating disorder, it is quite deeply embedded by the time people are seeing you.
Yeah, roughly around, you know, the earlier someone sees us for an eating disorder, the better the rate of recovery. If after 3 years, the kind of rates quite dip down in terms of recovery, but that doesn't mean it's not possible. It's just harder because it's more kind of embedded with themselves and their identity and who they are.
Okay. And could you tell us a little bit about bulimia?
Yeah, so as I said, bulimia is more kind of, I guess it's kind of, there is restriction there, but it tends to be kind of what we call binging and purging involved in that. So quite often it's based on someone eating kind of a large amounts of food, for example, in a small amount of time, but then purging that out as well. There can be yo-yo dieting is quite common in bulimia presentations, or there can be purging only, not binging. There can be exercising, as with anorexia as well, going to the toilet a lot after the meals, also having a hatred for their bodies as well. So it's quite similar but very different. Like I said, anorexia is more the restriction of the food intake, whereas bulimia is more kind of a yo-yo end, I suppose, kind of restriction, and then maybe eating large amounts and then purging that, or sometimes not purging that out as well.
Right, so it sounds like it's probably more difficult to identify.
Yeah, you know, we always say, you know, all the symptoms of eating disorders, whether it's binge eating, bulimia, anorexia, there's also something called offset as well. They're all quite, they have their unique symptoms as well, but quite often the symptoms kind of overlap. So you can have someone with purging anorexia, for example. So it's never quite clear cut. Sometimes it is clear cut, but sometimes it's not. But what we always work on is that person's needs, and it just highlights how complex mental health is, that, you know, no one quite fits into a category sometimes. Sometimes you can get those that come in with anorexia, and in their recovery journey, they then develop maybe binge eating disorder instead. So we never get fixated on one diagnosis because it always will change.
Okay. So this is interesting. What you're talking there about is that it's very complex, and I'm guessing when you're talking about complexity, you're talking there also about the underlying issues or what might have led an individual to restrict the diet. You mentioned in that letter earlier about impressing friends. Would you say? So what would you say is the presentation? Yep.
Yeah, I guess the kind of presentations will really vary. People's reasons, or, you know, kind of what the reason why they developed an eating disorder will vary across, you know, the age range will just vary across any person, really. We never kind of say it's due to trauma only, because we know that's not true. Sometimes people don't have traumatic experiences develop an eating disorder in the same way as in the field of mental health as well. There's no one kind of indicator of why a person develops an eating disorder or not. And bearing in mind, eating disorders are relatively new compared to kind of the mental health spectrum. As well, like binge eating disorder, it's only been around less than 20 years, as a diagnosis. So that shows we're still learning a lot about eating disorders and the etiology of it, and kind of the reasons why people go on to develop eating disorders and those that don't.
So there's still a lot of learning for professionals.
It is, yeah, and even the therapies and techniques, they're still quite new as well.
Yeah, with regards to binge eating, we do have a researcher who's looking at the topic of binge eating, who will be joining us towards the end of the show, so do stay tuned for that. And you're mentioning here that, you know, you can't limit it to one factor, but there are kind of, are there some common threads in terms of loss or bereavement, or the need to feel in control, or anything like that you might be able to share with us?
Yeah, sure. So you know, there are common themes, you know, I think they're themes that we share alongside those who have mental health difficulties as well. So, you know, there's that kind of feeling to be in control, or the feeling of being out of control and needed to have something, and the anorexia gives them that control as well. Loss does play a part as well. You know, kind of people cope with loss in very different ways. And we're a culture, especially in the Asian community, that food is at the heart of our community, isn't it? It's kind of there from the birth onwards. So there is a cultural aspect to eating disorders as well, which we can talk about a bit later on as well. You know, quite often there are people that do have traumatic experiences as well. That plays a part.
And what about age apologies, sorry. What about age differences when people are moving away to uni, for example, younger people? Do you find that sometimes triggers off disordered eating?
Yeah, I mean, for the population for eating disorders, again, is quite high as well. You know, kind of it's that individuation process, isn't it? Moving away from home, then going to another setting where actually you no longer know where you are, who you are, because you're taking on a different role as a student now. And there's something about independent living that we might struggle with, as opposed to dependent living when we were living with our parents or home where we're based at. So that is a triggering point as well, and a quite isolating time, especially during COVID and lockdown as well. We know the rates of eating disorders has sky high rocketed. That's been reported in the news already. It's a really isolating time, and what can we do when we're in our homes? Think more. Food is there, and kind of we all engage in emotional eating. You know, if you think back to kind of you know, even with the way we're brought up, for example, you know, if someone's crying, if one of our, you know, children or young person is crying, what do we do? Give them a chocolate. But what are we doing there? Teaching them how to kind of soothe an emotion is via food. So I always say, kind of, we don't always want, that's not unhelpful, but it's not helpful as well. So I think there's something about the neutrality of kind of finding other ways to handle difficult emotions, not via just food in itself.
That's an interesting point you raised in terms of early introduction to emotional eating without knowing it as parents.
Yeah, and even that if you think about it, you know, the way we're raised, you know, very subconsciously, I guess, that you know, we learn to differentiate food by kind of morals and values, don't we? So good food is you know, I don't know, fruits and vegetables. Bad food is chocolate, crisps, pizzas, chips, blah blah blah. You know, junk food and, you know, skinny foods. It's all out there. We can't escape it. But I think it's being aware of really not to kind of place morals and values on our food. Food is food. And that's what we'll try and teach all of our patients and our families as well, that actually, you know what, we have to relearn our relationship with food. It doesn't help by the food industry at all, but we have to work with what we have as well, all of us.
Yeah. And it's really important that we're not blaming parents actually in terms of this discussion.
No.
Yeah,
it's a whole, you know, kind of, it's a whole societal issue. It's not just embedded within families and systems. It is a whole kind of, it needs a whole change within our whole system. But we can only work with what systems we have.
You were talking earlier about the spectrum. I'm just wondering, if we have family members and we recognise that there's disordered eating patterns, we recognise perhaps, I don't know, whether there's a weight loss, or what kind of symptoms would we be looking out for, let's say, for anorexia nervosa or bulimia? And I'm wondering whether you can talk a little bit about weight and the normal
so
range.
if we're looking at for symptoms of I always say an eating disorder rather than separating into bulimia or anorexia. What we're looking at is physical changes in our weight. So, the rate of our weight loss, for example, secretive eating, going to the toilet after eating as well, over exercising, feeling quite weak and faint, unable to concentrate, hair thinning out, brittle nails, for example, yellowish skin, always feeling cold. If you can hear sometimes, when we have family members come in, they will say they notice a change in just when they're at the table and they recognize that, so-and-so stopped eating a dessert or stopped eating chocolate, for example, or would go upstairs into the toilet after each meal as well. So those are the kind of some of the things we kind of say, to recognize actually what is your relationship with food and what is your relationship with your body like as well, and how you see yourself, so your self-perception. And also kind of, I mean, the diet industry is kind of, it's so big and huge out there. What we do say is actually, be careful of kind of, there's a fine line between going down the dieting route to then developing an eating disorder as well, in order to kind of reach that goal of weight loss, because you might want a weight loss and want to be a size 8, but it will never, once you're in the grasp of an eating disorder, it will never leave you at size 8. From the poem you can see that it really overpowers your whole life, an eating disorder.
Yeah, and when you say an individual's whole life, I'm guessing that it has impact on family. We'll talk a little bit about that later.
Yeah.
So you said some of the common symptoms you mentioned there are going to the toilet after eating. Would that be a very common one then?
Yeah, that's a very common one, but that's more on the, let's say, the bulimia presentation. So wanting to purge, for example. But what you'll notice is people's relationship with food will start to change, and that's quite the common one. So like I said, for someone to kind of think, actually, does this person have, a difficulty in this area? I'd always say, look at their relationship with food and, kind of how they are at dinner time, for example, or, have they started skipping their meals? Weight loss, you'll see anyway visually, but that we always say that's not an indicator sometimes.
Right. So thank you for sharing all of those common kind of changes, I suppose, that people might be able to notice in their loved ones or family friends. I'm wondering, in terms of treatments for eating disorders, what would be the first point of support for individuals? I'm guessing GP, but
as always, it's always a GP, isn't it? One thing I always say is that it's really hard once you start to recognize, actually, you know what, I'm not in control of my food habit or my eating habits now, or I'm starting to dislike the way I look or how I feel. The GP is that kind of gatekeeper to mental health services, aren't they? So we always say try and reach out and make an appointment with your GP.
Yeah, you said that once we recognize, and I mean, that's important, isn't it? Because for a lot of people who have eating disorders, they probably don't realize until, like you said,
at that point. It's quite often, especially because I work in the all age eating disorder service, it's in the young people. For the young people, it's usually their families bringing them in because they haven't recognized that they have an eating disorder. So it's usually the families that will instigate a referral. So that's why I always say, kind of really paying attention to, kind of how the young person is at home during family times, weight loss. Sometimes schools recognise it as well, which is a good thing. So they're more on board with recognising eating disorders and the patterns of behaviour that might occur for someone in the midst of it as well. So they might then, talk to the families involved, and that might help with the referral route as well. But usually our referral route is via the GP.
Okay, you mentioned there a little bit earlier about noticing kind of weight. Could you tell me more about that?
Yeah, so kind of with an eating disorder, typically, like for example, with anorexia, it's we look at the kind of the rate of weight loss and how much they've lost as well, because that's just as severe. Usually, kind of we you know, on the BMI, which is what a scale we use, that's kind of used as an indicator or a measure of one measure of an eating disorder, but it's not the only one. So usually for someone that's below a BMI of 18, we start to think actually that's a cause for concern. Young people are, we don't use a BMI on for young people. We use a weight for height, which is like a very different measurement for them. But typically, weight is one way we assess for an eating disorder, or the rate of weight loss, which is just as important, but it's not the only measure. And
Okay, thank you.
You know, with an eating disorder, bearing in mind, you can hide your weight sometimes. So we have known people, young people, come into our service and they've had such incredible weight loss, but it hasn't been noticed because a young person or the adult has disguised it by wearing lots of hoodies or baggy clothes or wearing jeans
Thank
upon
you.
jeans. It's a very
Yeah.
secretive illness for eating disorders. And that's why I'm
Right,
saying,
Suki, can we pick up on this? Sorry to disturb you, Suki. Can we pick up on this after the break?
yeah, that's fine.
Fantastic. We'll pick up on this after the break. Hello and welcome back. You're listening to the Mental Health and Emotional Wellbeing Show with our guest today, Dr. Sukhbinder Bilku, the Senior Clinical Psychologist in the local NHS Eating Disorders Service. Sukhbinder, Dr. Bilku, sorry. Before the break, I had to suddenly cut you off. Sorry about that.
No, it's
and you were
okay.
talking about symptoms, and you were talking about how people could probably recognise eating disorders, or you know, a difference in how a person is presenting. You mentioned baggy jeans, and you were talking about kind of hoodies. Tell me more about that.
Yeah, so you know, with eating disorders, they're quite secretive. Like I said, you know, they really kind of isolate you away from relationships, but you form another relationship with an eating disorder, so it doesn't ever feel like as a loss. But you can disguise an eating disorder in some ways by visually anyway in the short term. It's never long term. So a person can be wearing hoodies, you know, baggy jeans, for example. So you never really recognize a rate of weight loss, but you might notice it in other areas. For example, in terms of, you know, when they're at the dinner table, they're no longer having the dessert or no longer eating potatoes or chips or anything, and just eating the broccoli, for example. So I always say kind of just, it's not just about looking at weight loss or visually how the person is, but more their behaviors and the patterns and how they've changed. And of course, even if it's from the early on, like a change in their diet or something, just kind of really keep an eye on it. Because like I said, there's a fine line between dieting to then kind of starvation.
Yeah. What kind of psychological interventions should are appropriate or helpful for individuals who are experiencing eating disorders? So when should it take place? When should it take place? I mean, some people say that actually you shouldn't have any intervention until the eating has been restored.
Yeah, when I started in eating disorders, that was such a common perception.
Right.
You'd hope that's changed now, because you know, and again, that was relying on a person's BMI. So lots of people professionals used to think if a person was at BMI 14, which is quite low, or even below 8, 13 or 12, then they didn't have a mental capacity or even an understanding or perception of the illness. But I just think, you know what, you know, it doesn't matter at what point a person is, you know, everything is therapeutic. You don't have to be like a therapist to be therapeutic. You can start a person's journey into therapy at any one point. Of course, you know, those that involve more dynamic therapies, they require a lot of mental capacity, for example, or concentration levels. But I think, you know, at a point, it doesn't matter where a point is at, as long as you're being therapeutic and meeting that person where they are in their journey of an eating disorder, then I think we start there. Because if we wait until the person kind of reaches a maximum BMI, we might be too late then. You know, for yourself, trust takes a long time, doesn't it?
Yeah. So to build that trust and build that therapeutic relationship, it's key actually to intervene earlier, right? Or to provide therapy and to meet the person where they're at.
And lots of people think, that to provide therapy is just to be from a psychologist or therapist. But when a person comes into an eating disorder service, there's other professionals. So you have the dietitian, you have an occupational therapist. Sometimes you might have art therapists as well, or play therapists. So you could start with seeing a dietitian. That's therapy in itself, to help them kind of develop kind of more healthier ways of eating, or formulating a meal plan, for example. That's therapy, but it's not traditionally what we'd see as psychological therapy, but that person is still getting something that's of therapeutic value.
Thank you. And we also hear about kind of family-based therapy. I'm guessing the family role can be pivotal and really supportive. Yeah. At the same time as perhaps there have been some bad experiences of family colluding with the individual. I don't know. How can people build positive routines around a family member who has an eating disorder?
I guess that comes with the treatment, with family-based treatment. So with family-based treatment for eating disorders, it's very different from the other family range of family therapy. So with family therapy in general, you explore relationships within the family system, or the positioning of each person, and their identity and resources. And that's a bit similar to family-based therapy, but the only difference is family-based therapy is an intensive form of treatment. You don't have to be a family therapist to provide family-based treatment. It's a very intensive form of treatment. Families are kind of take a key role in that person's recovery. It's quite kind of, it's a change, because actually you're taking in that model of therapy, you've actually taken over the young person's meal planning. So you kind of take over what they're not going to eat, but you sit with them breakfast, lunch and dinner, and they have to eat with a young person undergoing family-based treatment. Food is medicine, and with any illness you have to have your medicine to recover, and so it's very different. So it is collaborative, but ultimately the family are the experts, and we have to take some control away from that young person, and really help them see the severity of the eating disorder.
Yeah, you were talking earlier about the cultural differences, and here I'm hearing you talk about kind of the family playing a key role. However, in some cultures, it might be that the family really cannot get to grips with understanding that this is an eating disorder, and how can it be an issue, or how it has become an issue. What of the intervention for them? Is it different then in terms of educating?
Then we'd utilise more family-based approaches. So like I said, if the family isn't resourced enough, for example, if they are struggling themselves with emotional health difficulties, or finding it really difficult to take control of the young person in terms of what they're eating, for example, or their meal planning, we would help utilise and resource them. So kind of find ways for them to kind of really manage the young person and form a better relationship, so that there is a chance of kind of change happening within the system. Sometimes that's not always possible, and so we don't tend to use the family. Then we'll then go on to other resources, for example, teachers, for example, or someone else, a social worker the young person might be seeing as well. Yeah.
Right. So those are all the community and social workers.
Yeah,
and other professionals can play as well.
Yeah, we have to involve all the systems that a person has. If we can't utilise a family for various difficulties, we go to other systems, because that person isn't just located by themselves, living by themselves. We live in a social world, don't we? Lots of systems we're surrounded by, so we make use of that as well.
And in terms of the systems, is there more kind of awareness being taken into these into different community places, let's say places of worship or other community venues, meetings, etc.? Would you say that there's more of an effort to create awareness of disordered eating?
Well, this is the kind of $1 million question, isn't it, Atiyah? This is the kind of what the role play, what the community plays in helping with this kind of mental health crisis we have in this world today. We do our best. We work with faith leaders, we work with communities, but sometimes for itself, it's really hard to get into some of these systems. you know, kind of, we're not the gatekeepers. We can do our best to help you, you know, let's say, work with a young person and, for example, a faith leader, but sometimes the faith leaders aren't forthcoming. So we have to kind of work with what we have.
Absolutely. And my thinking was more around this awareness of filtering back into the families in terms of, you know, does your child, does your sibling, does your partner, does, you know, your parent, whoever it might be, have an eating disorder, and how would you identify those symptoms? And I suppose a part of this, the reason for this show is for exactly that purpose, to support individuals in identifying symptoms, and as well as those that are experiencing difficulties, to seek help.
Yeah, I just think ultimately what we should, any treatment package for a person, no matter what their age, should always be individualized, and they should always locate the eating disorder away from themselves. But that's our role, that's our job, because in the context of it, we live in a social, cultural, political world, and you know, it's never a person's fault that they've developed an eating disorder. You know, many systems have to play a part in that as well. Like, if you think about it, like, what use is 1 hour therapy per week in an eating disorder service if that young person goes back to a very chaotic and challenging home environment or system, if they're being bullied at school? I'm not saying it's no value having therapy, but you know what, we have to work with systems. You can't just work with the individual by themselves or their family members. So I think we all can play a part in that.
Absolutely. So do interventions kind of differ for younger children? You mentioned a little bit earlier about the relationship with food. Do you want to touch a little bit on that again?
Yeah, so with younger people, so in terms of kind of NICE guidelines, the interventions for children and adolescents are quite different to adults. I'd say they're more systemic, so we do involve numerous systems, like I said, school, local authorities, families as well. Whereas adults, they tend to be a bit more individualized, but I think it is changing because we recognize that actually we live in the context of relationships. So even in the adult end of our service, we do try and incorporate the resources that person has in their lives as well. So partners, for example, family members, they can always come in. It's not very prescriptive. It'd be a really sad service if we prescribed to totally just NICE guidelines and just worked with the individual. We know that doesn't work. We know that the treatments that have been recommended by NICE, for example, are quite new. So we don't really know the long-term effects just yet, because like I said, that you know, it's really, we're quite early on in our understanding eating disorders.
Yeah. Now we are coming quite quick to the end of the show with yourself, Dr. Bilku, and for our next guest, Claire, to come along and talk about her binge eating and her research around that. But what I wanted to ask you quickly was that with Ramadan fast approaching for many Muslims this month, many may be wondering whether Ramadan may be particularly difficult for people who experience eating disorders, and in particular anorexia nervosa. What do you have any thoughts around that?
Again, you know, we do have lots of you know, young people and adults, I suppose, who want to fast and take part in a very spiritual time for Muslims. But we have to always, you know, we have to always consider where they are in their recovery of an eating disorder. If we want to fast, we've got to make sure, if they want to fast, we want to make sure it's safe enough for them and the family, and if they're resourced enough. Sometimes that you know for yourself as a practicing Muslim, you know, we have to take into account how sick or that person is. So you know, would you really be fasting if you have diabetes or cancer, for example, undergoing treatment? It's the same thing. It's an illness, and we really have to consider the point at where the person is. And we always consult with the families and take into account, you know, if they want to speak to a faith leader as well. We have a spiritual care team in our service as well. But what I always say is, just lastly, is that you know, it's fasting and not restriction or starvation. So that's a main point to that. But actually considering, again, it's a fine line, isn't it? And it's quite a triggering time as well.
Yeah, thank you for that. That's and you're right in terms of the culture and religious implications of somebody not fasting or not being a part of
I think just generally, Atiyah, we have to get away with, and this goes for all religions, that it's always based on, or traditionally people perceive it as, how religious you are is how you engage in certain activities or behaviours within within our religions, and it shouldn't be viewed as that or judged as that.
Absolutely, and especially when somebody's poorly, you know, when someone is sick.
You are.
Yeah, absolutely. And in terms of when somebody is feeling sick and poorly, in terms of family and community supporting that individual, it's really important for them to recognise that some people aren't fasting, and that would be because of them feeling poorly. So it shouldn't really be encouraged, especially when people have eating disorders.
And they shouldn't have to justify that to anybody. You know, anyone has their own relationship, don't they, with their faith?
Yeah.
You know, like I said, there's no one out there to judge, and it's not a weakness.
So how? Yeah. Thank you. So how do we develop this healthy relationship with food, do you think? And I know that Claire's coming on to talk a little bit about binge eating and might touch on that, but do you have any last seconds of advice in terms of developing healthy relationship?
I think it takes a lot of work, but it starts very young for a person with or without an eating disorder. We have to unlearn all the things we've learned and relearn our new relationship with food, and being mindful of the morals, values, judgments we place on food, but also we're not taught how to love our bodies. We see our bodies as quite separate, don't we? You know, kind of a mind and body. By that point, we focus so much on the mind and not enough about our body. So I think it's about really also not just about food, but helping to develop a healthier relationship with our bodies and who we are, and how that we're embodied creatures.
Absolutely, thank you. Dr. Bilko, can you guide us to any resources that might be helpful for people requiring further information about eating disorders? And would you kindly also leave us your contact details if there's anybody who wants to get in touch with you?
Yeah, sure. So, you know, you always say to anyone, there's lots of information on the internet, but I always say go to Beat. You know, the Beat is the main kind of is a helpline and a website as well that shows you kind of all the different types of eating disorders and what to do. They even have a referral form on there that you can fill out and to give to your GP as well. So
what does Beat stand for? What does Beat stand for?
Oh, you're going to ask me. It's,
oh, okay. That's okay. So would you be able to give
BAT, if you Google it, but eating disorders, basically it'll be on there. But there's also kind of, you know, the NHS sites as well. But I always say go to your GP in the first instance if you can.
Okay. And for your contact details, do you want to provide them?
Yeah, so I can give you a link afterwards, but it's Dr. Sukbinder Bilku, and you'll see me under MedStars, and clinical psychologist. You'll find me on my Google search.
Fantastic. Okay, so towards the end of the show, we will be providing you with further online resources and hopefully be able to give you the acronym for BEAT as well. Thank you, Dr.
I should know, shouldn't I? Yes.
No, well, we know them as acronyms, and that's the case. So
I think it is just called BEAT. It doesn't mean any. I think it is just generally called BEAT.
Oh, right, beating the disordered
eating. Yeah, it's called eating disorders.
Thank you, Dr. Bilko, for joining us on the show today.
No, that's okay.
I'm sure people will get in touch with you should they need to with regards to disordered eating or any other issues that they might have. Following in a short while, we will be speaking to Claire. Thank you again, Dr. Bilko.
No problem. Thank you.
Bye for now.
Bye.
I'd now like to invite Claire, a counselling psychologist trainee at the University of Wolverhampton, who is currently focusing on binge eating for her research. Thank you for joining me today, Claire. I'm just wondering, what interested you in this topic?
Thank you for having me, Tia. That's a good question. When I started working in mental health, I was really surprised by the number of people for whom dieting and overeating caused a lot of misery. So people would tend to get referred by their GP for anxiety or depression, but problematic eating was often part of the bigger picture. So recent research has backed up my clinical experience, which is that people who struggle with binging often don't get help. And that might be because they don't meet the full criteria for diagnosis of binge eating disorder, but often it's that they feel too ashamed to ask for help. And I think people's solution to these struggles is to diet, and there's a lot of support for that in the community. But as a psychologist, I think it can be really helpful to understand how dieting and restricting calories can trap people in a cycle that actually makes binging more likely.
Right. So what are your views on why the focus on eating disorders and binge eating is fairly new in comparison to other mental health problems? I think Dr. Bilker was mentioning earlier, I don't know if you heard, around it being a fairly new area of focus.
Yeah, it's a tough question, that one. I'm not sure I'm the right person to answer it, but I'll hazard a guess. I think historically, modern psychiatry has taken responsibility for and focused on people with mental health problems who pose a risk to society or a severe risk to themselves. So with the exception of anorexia, where the risk is to the self, the eating disorders don't pose a risk to anyone else, and the harm they cause to the individual occurs over quite a long period of time. But also, I guess if we think about the eating disorders, binge eating was the last eating disorder to be identified. And that might be because binging only occurs in societies where there's the possibility of storing excess food. And that's quite a relatively recent phenomenon. And that's not true of the whole world, as we know. So changes in the way food is processed, marketed and distributed means it's a lot easier to acquire high energy food quickly, and it's placed where we could see it and it's available all the time. And that's affected obesity levels as well as binge eating behaviour. I guess from a societal perspective, there's a lot of harmful myths about bulimia and binge eating, such that, for example, they only affect teenagers or young women. The idea that this style of eating is a lifestyle choice, and the dieting industry has grown up around these kind of assumptions. But the reality is binge eating is a complex condition that's affected by lots of different factors, but it's very involved with experiencing emotional difficulties. And that involves getting caught up with thinking about the need to conform to certain size and shape ideals, and the idea that that will relieve emotional difficulties. So that's what's missing, really.
So when does binge eating become a problem? When is help, do you think, needed for people who are experiencing this?
Well, quite. If we look at binge eating as a behaviour first, just in case people aren't sure what that involves, it's eating an unusually large amount of food in a very short space of time and feeling like you lack control over that eating during that episode. So binge eating is typically associated with things like eating very fast, eating until you're uncomfortably full, eating when you're not hungry, and often eating alone because of feeling embarrassed of either what you're eating or how much. And afterwards, the temporary relief caused by the binge doesn't last, and feelings of disgust or shame or depression or guilt kind of swarm and overwhelm people at that point. To meet psychiatric criteria for binge eating disorder, you'd have to binge at least once a week, and you'd have to be doing it for 3 months, and you'd have to feel that binge eating causes you a lot of distress. And you're probably aware from the previous talk that binge eating is different to bulimia because people who binge don't purge. Has that been covered?
Yes.
Yeah, okay. But the research on eating disorders shows that over a lifetime, people who struggle with eating behaviour will meet the criteria for often all 3 or different disorders at different times. So I think in terms of when binging is a problem, it's about binging existing on a spectrum of severity rather. And because it doesn't tend to lead to life-threatening complications, it tends to be more hidden, and binging occurs in private. So it might be helpful to think about the behaviour as a problem if you recognise that it causes you a lot of distress, because it's likely that the long-lasting effects of binge eating, if untreated, are quite severe. So that's associated with long-term depression, with overweight or obesity, and that increases your risk of diabetes, heart disease, and sadly, as we've learned recently, COVID-related mortality. So the long-term effects are what motivate people to seek help. And I think having that distress, or if you're worried about someone who you think is binging, it's about being able to approach that person in a kind of compassionate way because of the shame. And a first step could be just looking at the binge eating disorder website, so BEAT, that's a charity of supporting people affected by binge eating, and getting information there. But it's important that it causes you distress and you're motivated to change something and to engage in treatment. Right.
Claire, you mentioned there about people who binge eat don't usually purge. Sorry, there wasn't much of a focus on that, but thanks. So what you're saying is that they don't usually purge, people who binge eat. Yeah.
Yes, people with bulimia can overeat, but because of the purging, they can typically be, you know, a normal weight or slightly overweight, whereas people who engage in binge eating don't usually follow through with purging, so that they can get into trouble with overweight.
Right.
Because it's about eating in private and losing control, and sometimes even your connection to sort of time and what's happening when you do that kind of eating.
Right. So what kind of interventions are available for binge eating? What kind of support is available? What interventions? What psychological interventions?
Yeah. There's a surprising number of therapies for binge eating, but the most common ones are a specialised form of cognitive behavioural therapy. And these therapies target a few key psychological mechanisms. So they work on reducing the belief in the usefulness of worrying about body shape and size. They increase mindful attention, or they help with recognising and managing unexpressed and difficult feelings. At the moment, the research into binge eating is converging around the view that binging is triggered by feeling angry and sad, but also feeling disappointed, hurt, or lonely within your relationships. So if you've noticed that, that again is a useful point to think about asking for help. And I'm interested in that aspect of eating behaviour, because we know that if you deny these feelings or focus exclusively on them or the thoughts associated with them, that will make the binging worse.
Right. So tell us how this brings us on to your study. Tell us a bit about your study and
yes, obviously the exciting part. I'm looking at a therapy called acceptance and commitment therapy. So we tend to say ACT, to shorten that down. So ACT has been really effective at helping people with long-term conditions like chronic pain or addictions, and because eating behaviour is often quite long-term and chronic. When it's been trialled with binge eating behaviour, it's been effective, and that behaviour change has been more long-lasting. So ACT is a therapy that has several different components to it, and they work on different aspects of coping. And I'm trying to find out, if we were to take just a small part of this therapy and teach it to people in 1 hour, whether that would be as effective as a whole therapy delivered over 6 to 12 sessions, for example. So that's ambitious, but in other areas, researchers have had success with these very brief interventions.
All right. So what kind of participants are you looking for? Who are you looking for your research?
If you've been diagnosed with an eating disorder, you'll already have received this type of support, so this study's not for you. So I'm looking for people who've perhaps had a long relationship with dieting and who think they might binge eat or overeat. So if you can spare an hour and you're able to get online, please get in touch. I'm running 3 different types of 1-hour workshops, and one will look at how to upset your feelings, the other one will look at how to reduce the control that unhelpful thoughts have over you, and the final one will look at how to consciously choose what you eat and when you eat when you're feeling overwhelmed.
Thank you, Claire. Yeah, we are now coming to the end. It has been very informative, the show today, the information that you've provided and Dr. Bilker has provided. How could listeners get in touch with you if they wanted to take part in the research?
Yeah, if you want to know more about the research, you can go onto Eventbrite online, and the study is on there. It's called ACT on Your Eating Habits. So ACT, A-C-T, on your eating habits. You could email me directly, and unfortunately it's a long email. c.l.cotterill, C-O-E-R-I-L-L, at Wolverhampton, so that's WLV.ac.uk.
Fantastic, thanks, Claire. And people can also get in touch with me if you didn't quite catch the email, or you want further information on how to get in touch with Claire. As Dr. Bilker mentioned earlier, and Claire has mentioned, there is the BEAT website, which is www.beateating disorders.org.uk, and there's lots of helpline resources on there, and there's also a helpline which is open, which is running during the day and over the weekend. As mentioned earlier on in the show, you can catch more mental health information on my Twitter feed at Atiyah Ali 3, or you can listen back to this show and previous shows on Ramadan Radio's YouTube channel. Thank you for listening in. You will hear from me on the first Saturday of every month, and the next show will be on the 1st of May at 1 p.m, where we will be focusing further on mental health awareness and suicide prevention with our guest, Poppy Jaman. If you have any questions for our guest, please email them into the radio, Ramadan Wolves, or contact me via Twitter, and I will try my best to get them asked. Thank you again for tuning in today, and do listen back to this and other clips. Goodbye for now, and have a lovely Easter bank holiday weekend.